All right, let's talk about blood gases and oximetry, page 19. It's kind of a hodgepodge of things that have to do with blood gases and pulse ox. Actually, it's kind of fun. There's some kind of interesting things in here. And it starts out with the idea that oxygen, supplemental oxygen is ordered a gazillion times on admitted patients, and how often is it necessary? And it always reminds me when you walk into the emergency department, you're coming on a shift, and you kind of walk through the walking wounded area, and then you walk through the bed area, and all the patients that have their oxygen sort of feeding their forehead beautifully, the nasal oxygen is slipped up, and it's sort of sitting here on their forehead. Is that happening in the hospital as well? You bet your life it is. Abstracts number 1 and 2 basically said that, in abstract number 1 looked at 250, 200 and some patients that were admitted upstairs that had orders written for supplemental oxygen, and found that almost 80%. It was either too much that was ordered, or it just wasn't necessary at all. And one of the abstracts actually calculates the amount of money. Number 2 said that this particular hospital could have saved $700,000 a year by just not having oxygen used in patients that didn't need it. It is one of those interesting things that makes me wonder when people are looking at the finances of medicine, why they don't look at things like this that actually could make a significant, like washing out wounds with tap water instead of sterile saline, things like that could save some money that are easy actually things to do. That one actually says we overuse it considerably in the hospital setting. I'm not so sure in the ED we overuse it. I think we're pretty good at that, mainly because of abstracts 3, 4, and 5. When I'm old enough to remember, it's really weird to be so old that you remember IVPs and stuff, but I remember we didn't have pulse ox when I was practicing. I learned medicine. We didn't have a pulse ox. That idea, that little clothespin on your finger thing, we just didn't have one. Does it make us better as practitioners to have pulse oximetry readings? Should it be the 5th vital sign? Now, it shouldn't be the 5th vital sign in somebody who has an ankle sprain. I don't even care what their blood pressure is if they have an ankle sprain. But if it's somebody who has a cardiopulmonary complaint or shortness of breath complaint, should it be the 5th vital sign? What do you think? Should we be getting it in everybody? You bet your life we should. Abstracts 3, 4, and 5 basically say our ability to clinically determine whether someone is significantly hypoxic, other than we have blue down, we have that whole cyanosis down, we're pretty good at that. But if somebody who sits at a pulse ox of 90%, has a PaO2 of 60, okay, that's what their blood oxygen level is 60. If your pulse ox is 90%, can we detect that? The answer to that is absolutely no. We cannot detect that. Abstracts 3, 4, and 5 look at it. Our clinical impression of picking up somebody who has a sat down to basically 92% was abstract number 3. Our clinical ability to pick that up is only 33%. We miss it 2/3 of the time. We just can't pick up hypoxia. We're just not very good at that at all. If we think it's there, if we think they're hypoxic, we're more specific. If we say, yes, I think they're hypoxic, we're pretty good at picking that. We're still not great at that. That's still only 86%. The bottom line is, it is important to know, and it changes our practice. There's a difference between knowing a piece of information and saying, yeah, that's fine, versus knowing a piece of information that makes a difference in your practice. This does both. We're not that good clinically at determining somebody who's hypoxic, and it definitely changes our practice, which is what abstract number 4 looks at. And how many of you have ambulances where they do pulse ox in the field? We do. I'll tell you, that is really helpful. Paramedics can't determine it either, and that really is helpful for us to know how hypoxic somebody might be out in the field. So it is probably worth having that as the 5th vital sign. And of course, now the pain scale is the 6th vital sign, and the head circumference is the 7th vital sign. I mean, it's gotten kind of crazy. But this one clinically makes a big difference in what we do. If you decide to give oxygen, I did 2 residencies. I did internal medicine first at UCSF, and then did emergency medicine at Harbor, and that wasn't by design. That was strictly by happenstance, because I found out I hated internal medicine and decided to go back and do a second residency, which shows that I do have some smarts somewhere along the way that I changed my practice. But I was taught to humidify oxygen. I was taught to go, we need to, if we're going to put the nasal cannula in their nose, we need to bubble it through the, good humors here and humidify it so it doesn't dry up your nose and give you nosebleeds and itch and hurt, etc. Does that do anything? Nah, it really doesn't. Abstracts 6 and 7 look at the humidifying of oxygen. Does it really do anything? I have a suggestion for you. I think there are certain things that every emergency physician should have to go through so that you have some empathy with your patients. Once, at some point in time, go put a C-collar on and try it, and lay yourself down on a backboard and have somebody tie you down. You will want to get people off the backboard as soon as possible if you've ever been put on a backboard in a C-collar. The other thing you should do is take nasal cannula, close the curtain because your colleagues think you've lost your mind. Take nasal cannula, put it in your nose, plug it in the wall, and turn it up. 1 liter, not so bad. 2, okay, I'm good with that. 3 starts to get uncomfortable. You get up to 4, it's not comfortable at all. And by 6, you feel like your nose is getting blown off your face. Somebody is blowing a 747 up your nose. It is really uncomfortable to have that much oxygen going. The idea was humidifying it makes a difference. It doesn't. And actually, if you look at abstract number 6, humidification made absolutely no difference in patient discomfort. What makes a difference is the flow. So at flow over 6, you shouldn't go there. Probably flow over 4, you shouldn't go there. Abstract number 7 says, if you do decide to humidify, you don't need to use sterile anything. Tap water is fine, but they do have a caveat that if you live in places like Philadelphia, look for Legionella, because it's probably not a good idea to blow Legionella up people's noses. So tap water is fine, unless you live in areas that are Legionella or atypical mycobacterium is a problem. So that's probably not good.
Can they say what it looks like?
Yeah, that's right. Exactly. All right, do we overuse blood gases? The answer to this is yes, 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 and yes, across the board. And we're going to spend a little time on blood gases in general. Abstracts 8 and 9 look at the use of blood gases in the hospital. I had the dubious honor of spending my 5th week of medical school in the intensive care unit at George Washington University Hospital. I was the 2nd reported case of toxic shock in the United States. Got sick as a dog. Wasn't intubated. However, because I was in the ICU setting for a week, I had a blood gas every 8 hours. I had an art line in. I had a blood gas done every 8 hours. I wasn't intubated. My status didn't change once I got stabilized. My status didn't change. It was fine. But I got one every 8 hours. Absolute baloney to do that. Garbage to do that. Getting your artery stuck hurts like a son of a bitch, I have to tell you. It is really uncomfortable. Art lines are not comfortable. And the blood gas information doesn't change management in a lot of people that are in the ICU. Another huge area for cost savings. And abstract number 9 just put, if you work at all near the ICU or work with the intensivists, it's a lovely guideline for when go ahead and get it, otherwise don't. It has specific criteria where it's worth getting a blood gas and follow-up. And I have to tell you, for us in the emergency department, when you have people in your ER for 5 days, like we do, who are intubated, these are the kind of guidelines we use to decide whether we need to get a blood gas in somebody or not. It's changes in status, et cetera, those kind of things. But we definitely overutilize blood gases in general. How many of you ever had one drawn, an arterial blood gas drawn? It's awful, isn't it? The reason it's more uncomfortable, and it is flat out more uncomfortable than a venipuncture, is that your artery has a vasa nervorum that your veins don't. So an artery is surrounded by a little nerve plexus that is trying to protect your artery. You're not supposed to be poking at it, and it hurts like crazy to get a blood gas. If you decide to get an arterial blood gas, can we make that more comfortable? The next set of abstracts say absolutely yes, you can. There's sort of anesthesia for arterial puncture and how to do them. Abstracts 10, 11, and 12 look at how to do them. They talk about contraindications. The only significant contraindication is a bad bleeding diathesis of some sort, where they may actually get a clot there and clot it off. And it does mention that you should probably be doing the Allen test if you use a radial artery. I've only had one of them go bad. We actually had a guy who did not have a good ulnar pulse and did clot off his radial artery in our ER. It was kind of a mess. You should probably check the Allen test, which checks the perfusion of both of the arteries to the ring and to the arc in your hand. Probably is worth checking. There's a couple abstracts in there on how to do them. Abstracts 13, etc. look at anesthesia. I will tell you what does not work. If you want to have a pain-free ER, which actually Jim Ducharme, who's a Canadian physician, is a big proponent of pain-free emergency medicine, one of the things you can do to make blood gases less painful is to use anesthetics. What does not work is topicals. You can use things like EMLA and LET, the topical creams for venous punctures. It doesn't work for arterial punctures, and it's the same logic. The nerves at the cutaneous level are anesthetized, but it doesn't get down to the nerves in the vasa arteriosum, okay, the nerves that actually go to the artery itself. So it doesn't anesthetize that. If you want to anesthetize, all of these papers, and these 4 or 5 that are here, say it has to be a local infiltration of topical if you want to anesthetize. Now, what is also interesting in some of these papers, and it is an argument used against doing any sort of topical at all, is that about 15% of patients found that the shot for the anesthetic was more uncomfortable than getting a blood gas. That's sort of up to the patient. And a lot of people, to be honest with you, don't do it. If you ask house staff, there's a paper in there on house staff, they're like, you must be kidding. I'm tired, I've been working really hard, and I'm not giving anesthesia, I'm just going for the blood gas. So house staff don't do it at all. Do you need to send a blood gas on ice? If you decide to draw it, do you need to send it on ice? In our emergency department, we have one of these carousels where all the charts are supposed to be in it. It's one of those round things that spins. And what we'll do when we get a blood gas is somebody will get the blood gas, stick it in the ice, zip the Ziploc bag, stick it on top of that thing, and yell, blood gas to go! It sounds like, some burgers, some fries, and a blood gas to go. That's how that is supposed to sort of tell one of our nurse attendants that it needs to get taken to the blood gas lab. Usually you see it sitting there in a pool of water about 3 hours later. It hasn't gone anywhere. Do you need to put it on ice? How many of you have blood gas machines in your emergency department? Okay, you all absolutely do not need to put it on ice. If a blood gas is going to be sitting around for more than 20 minutes, half hour max, you don't need to have it on ice. Okay, it doesn't change anything in your blood gas measurement. And the two abstracts that are there basically point it out. If it's going to be more than 20 to 30 minutes, you probably do. Now, I have a situation for you. We had this happen relatively recently. You have a patient you go examine who's just feeling kind of malaise, youngish, 30-year-old guy, feeling kind of malaise, just not feeling really well, just feels tired and had some sore throats. It just doesn't feel good. Okay? Vitals look pretty good. Pulse ox looks great. God knows why. He had a blood gas sent. We had a call from the lab. Blood gas is normal with the exception of a PaO2 of like 36. Go look at the pulse ox machine and it's 99%. PaO2 on the blood gas is 36. What in God's earth happened here? Was it on ice? Yep, it was on ice. What happened? It wasn't, good question. It wasn't carbon monoxide, because carbon monoxide does give a false elevation of your, but usually your PaO2 in your blood is normal, even in a carbon monoxide. The lab called us with a critical value about 10 minutes later. He'd had all kinds of blood tests sent. Which blood test came back at a critical value? His white count was 900,000. He had acute leukemia, and those leukemic cells chewed up the oxygen in that little tube when his blood gas was waiting to go upstairs. It's one of those, being a practitioner is kind of really cool sometimes. It's like, in retrospect, that should have been my clue. When I got this blood gas back with just the oxygen down, everything else was normal, that didn't make a lot of sense. His pulse ox was 99%. Something in that tube, something was wrong in that tube. It was a bazillion white cells chewing up the oxygen so fast that it had basically chewed up all the oxygen by the time it got put into the blood gas machine. Kind of cool. I thought that was kind of interesting. It's one of the few false lowerings that you'll see when actually his oxygenation was just fine. Okay, I have a question also for you guys. How many of you no longer do arterial but now do just venous gases? We virtually never do arterial gases anymore. This is a very appropriate practice change. Okay, it is less morbid. It is almost as accurate for the things that we really care about. Now, a couple of things. Gases in general are really not that helpful across the board. Okay, we used to get blood gases for everything. When I was an internal medicine resident, we got them for everything. Every DKA'er got a blood gas. Every COPD'er got a blood gas. Every asthmatic got a blood gas. We know that's useless. Okay, that is useless. If for some reason, because I have a pulse ox, my pulse ox tells me what the oxygenation is. If I really wanted to know the CO2, I can do a capnography. Okay, I can do that by their exhaled CO2. I can just go grab that, have them breathe into our little machine, and I can get that. What I really care about is the pH. If I get a blood gas, that's usually what I'm looking for. And that's things like toxic alcohols, sometimes DKA, but often I don't even care in DKA. The toxic alcohols are the big one, sort of the poisonings kind of issue. Overall, gases are kind of overused in general. But if you need them, can you do a venous instead? The answer is yes. The next set of abstracts look at venous versus arterial gases in certain kinds of clinical situations. And what you want to know as a practitioner is, okay, if I decide to get a venous gas, and it's a DKA'er, is it good enough to get a venous gas? Or if it's a COPD'er, is it good enough to get a venous gas? What if it's a coding patient and I get a gas? Is it good enough? That's what I need to know. Does it translate? Couple rules of thumb. If a venous gas is normal, the arterial gas is normal. So you don't have to go chasing with an arterial. If you have a venous gas that is normal, pH is 7.4, PaCO2 is, whatever, it's 35, the PaO2 is 90, you're done. You're finished. You don't need to do it anymore. You are finished. You don't need to go chasing arterial. So normal is normal. That's kind of cool. That's kind of nice. The flip end of that is a gas in a coding patient, a venous gas in a coding patient is not good enough. The problem is that your perfusion is not good enough for your venous sampling to be an accurate sampling. There's too much stasis of blood in somebody who's coding, where you're getting a local stasis pooling of blood, not a true circulation of blood, where the arterial and venous sides aren't that different. So in a code, it's not good enough. Your pH can be off by as much as 0.2. Your PaO2 and PaCO2 can be off by several orders of magnitude over what is found in a perfusing person. So normal gas in a living person, great, you're done. Normal venous gas. Venous gas in a coding person isn't good enough. And to be honest with you, gases in coding people aren't that helpful anyway, arterial or venous. They're just not that helpful anyway, overall. How about the medical conditions? If you're worried about metabolic acidosis, so you have somebody who's an aspirin overdose, is a venous gas good enough? The answer to that is yes. Particularly, it is good enough for the bicarb and the pH. You will find that with metabolic acidosis, with hypercapnia, and when we get into the DKA stuff, the place where venous and arterial can differ enough to be clinically important is the PaCO2. pH isn't, PaO2 isn't, not clinically significant enough. PaCO2 can be, but to be honest with you, think about your practice. How often does a PaCO2 hugely change what you do? Pretty rarely. Pretty rarely. So overall, for most things that we care about, a venous blood gas, particularly for pH or PaO2, is just fine. PaCO2 is the only place it's a problem. And I have to tell you, with DKA, these days, I don't think gases are indicated almost ever. Truly, almost ever, unless it's just somebody critically, crucially, awfully sick. You can diagnose DKA with a rapid sugar and a urine ketones. And you're done. You don't even need you don't need a gas. You don't need blood tests. I mean, to get that, you know your diagnosis. The only reason that we send the labs is to follow their course as they improve. But to make the diagnosis, you just dip for ketones, you check a blood sugar. You're done. The sensitivity of that is astronomically high, 90 plus, 95, 98%, hugely sensitive. So very easy to diagnose DKA these days without any blood tests except a finger stick. Okay, that's the bottom line of VBGs versus ABGs. Oh, okay. So we had a little goth population that came to our ER for a while. They had moved into some local building, and so all the black-haired, white-skinned, multiple buckles on their boots, black fingernail polish, goth kids. I don't know. They just moved in locally, so we had a bunch of them coming through our ER for a while, and does that nail polish, that black nail polish, affect my pulse ox? Does it? Yes. There's a paper in here. I love this paper. It's abstract 30. What they did in this paper is they wanted to know if color of fingernail polish affects your pulse ox. What they did, now imagine this. Grandma has just had a hemicolectomy, and she's in the ICU. And you're going in to visit Grandma because you are a good grandchild. And you're going to go in to visit Grandma again today. And you walk into Grandma's room, and she has one pink, one red, one black, one blue, one green, 9 different colors of fingernail polish on, which is how they did this study. They took ICU patients, they painted one fingernail each color to see if they affected the pulse ox, and then they left one natural to see what the difference was. And they found that the really dark colors did affect the pulse ox, significantly enough to alter your practice, because the number would have been low enough for you to do something. So black, dark green, dark blue, that can affect the wavelength penetration, but those are the only ones. Pink is fine, even red is fine, actually, it turns out, but the dark colors were a problem. That was abstract number, number 31. Abstract number 30 says skin color does not make a difference. Even very dark pigmented people, it does not change your pulse ox. And abstract number 3 says those lovely acrylic fingernails, not so much. Those things really affect your pulse ox. Now, those of us that work in hospitals aren't supposed to be wearing them anymore. I never have, because I just think it's kind of weird, but whatever. They definitely affect your pulse ox, though. So in those cases, you can try going transverse if you don't have time to take the nail off. Take your pulse ox and just rotate it 90 degrees. Decreases the sensitivity somewhat, but at least it gets you some sort of reading. But you can't go through the nail. If you need to take those things off, you need acetone to soak it off. It has to be soaked off. If you try to pop it off, sometimes the nail comes with it. Bad form. No style points for that whatsoever. So you really would prefer to get that nail off. You need acetone. We don't have acetone in our hospitals. It's one of those banned products. It's locked up in some safe somewhere. What we usually do is send somebody across the street to the drugstore to go buy some and come back, and that's how we take the nails off people if we need to. So acrylic nails definitely can make a difference. A couple other sort of hit and miss things on pulse ox. Abnormal hemoglobins. Do they affect your pulse ox reading? We're going to talk tomorrow in the provocative articles thing in the panel about hydroxycobalamin, which is actually an IV med that you give. It's basically a progenitor of vitamin B12 that you give for people who have cyanide poisoning. It's a cyanide reversal agent. It actually is a great treatment. The problem is that it totally screws up your blood gas. So if you have somebody who got that drug, it's going to screw up your blood gas. And methemoglobinemia also screws up your blood gas. Abstract number the next one, whichever it's 34. I love this study. Can you imagine? You go up to 10 volunteers and you say, you know, you guys, I'd like you guys to go stick your head by the tailpipe of a car until your O2 carbon monoxide level is 15%. Would you do that for me? So I can just check a pulse ox. And then you 10 over here, would you mind if I infuse you with sodium nitrate till I get a methemoglobin level of you up to 12? Do you mind, awfully? They'd have to pay me a lot of money. They did that for this study. They looked at methemoglobin and carboxyhemoglobin to look if they affected your pulse ox. They absolutely did. Interestingly, carboxyhemoglobin falsely elevates your pulse ox. It's one of the few things that will falsely increase your pulse ox. You are starving on the cellular level, but your pulse ox looks like life is beautiful. It isn't. It's one of the few things that, by the way, that's in the LLSA 2008 set of articles you have to know. That's one of the articles is on carbon monoxide poisoning, and that's one of the questions. Just, you need to know. One of the things that can falsely elevate your pulse ox. Abstract number 36. When I was an internal medicine resident, I was told the following. It was like set in stone. If you change oxygen, or you turn it off, or you turn it on, you have to wait 10 minutes for everything to equilibrate before you get a gas. Does that make sense? Does that make sense at all? Think about what you do in your practice. A patient comes into the pulse ox of 89%. You put them on oxygen. Pulse ox goes up to 99%. How long did that take? We stand and watch it happen. Why would you be waiting? What's the magic of 10 minutes? What they did in this particular abstract is they said, whoa, 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 whoa. Hang on a second. They looked at normal patients. They took a bunch of normal folks. They found that people equilibrated their oxygenation, their oxygen saturation, and their blood gas within 2.8 minutes. So less than 3 minutes is all you have to wait if you really want to get an accurate blood gas. But wait. What about those lung disease patients? They must equilibrate a lot slower, right? No. The lung disease patients, COPDers, 3.5 minutes. There's no magic to 10. You could draw the blood gas within just several minutes of changing oxygen settings, either turning them off or turning them on, and it's just fine. And abstract number 37 is a Mike Callahan paper. Mike Callahan is the chair at UCSF. UCSF has a new residency program starting in, now. It's kind of exciting for them. He is kind of famous for publishing papers that you want to go up to him and say, Mike, can I just slap you? Why did you publish this? Some lawyer's loving this paper. One of his papers he published is called Thunderclap Headache. And it's a single case report of a guy who had, oh my God, terrible headache, nausea, vomiting, got a head CT, got an LP that was negative, sent home. A couple days later, oh, terrible headache. Back again, got a head CT, got an LP, all that was normal. Came back the third day with the bleed because he had an aneurysm that had probably just stretched. And he called it Thunderclap Headache, reports like 3 or 4 other cases that are in the literature. I'm like, Mike, you're killing me here. This is like that. This is actually an interesting paper. He starts with 3 cases of the hyperventilating patient. We get this on the radio all the time. We've got a 23-year-old female here who's kind of hysterical. She's got tingling in her fingers and tingling around her mouth. And she's got kind of cramping in her hands. She's hyperventilating. We can't get her to calm down. Can we just have her breathe in a brown paper bag? And I am sure you've had colleagues that have done this in your emergency department. I guarantee that's always the pulmonary embolism patient, right? That's always the woman who just threw a PE, and she's panicked and freaking out because she just clotted off half of her perfusion to her lungs. He reports on 3 cases, 2 of whom died. Oops. Sorry, brown paper bag probably wasn't a really good idea. And if he'd stopped there, that would have been a bad paper. Would have been interesting and funny, but bad. What he did instead is he went on and took 20 healthy volunteers, and he had them hyperventilate on purpose down to 20. Remember, I don't know, when I was a kid in school, we always had the kid that was on the playground in elementary school who went out there and did that whole until they passed out. I don't know what the fun was of that, but there was always somebody who did. He took 20 volunteers and had them breathe down to a PaCO2 of 20, and then he gave them brown paper bags. And what he did that was interesting is he took a sensor in the brown paper bag to see what happened to the CO2 and the O2 in that brown paper bag as they held it against their face. Couple things. No patient got their own PaCO2 back up to normal, not one. And in fact, 22% didn't get their PaCO2 even up over 35. And the inspired oxygen dropped by as much as an FiO2 of 44. It dropped down so far that people were breathing in FiO2s of 6-8% instead of 21%. I mean, they were dropping it way down. So what they were doing is getting hypoxic. They weren't getting their CO2 up at all. And it was and these are healthy volunteers. Take somebody who's just thrown a PE. Oh, let's see. Let's let them breathe, an FiO2 of 8%. That's helpful. Not so good. So I think it was an interesting paper. Brown paper bags are not a great idea in hyperventilating patients. Any questions on this pulse ox stuff? It's kind of interesting. It's kind of a hodgepodge potpourri of stuff. All right, who's next?